Hi, Rita. How are you?
Hello, Commissioner Grimig. How are you?
I'm good. Thank you.
Good. Just FYI for everyone who is on now, we are live on YouTube. You are visible and also audio, and the public can also hear you. And so if you want to go ahead and maintain yourselves muted until we're ready to start. We do not have a quorum yet. Hello, Commissioner Sorota. How are you?
Fine, how are you all?
Good, thank you. Just want to let you know that we are live on YouTube so the public can see and hear you. We're asking everyone to keep yourselves muted until we get the meeting started. We do not have a quorum yet.
Okay. Well, I shaved, so
Hello, Commission President Mandel. How are you?
Good. How are you? It's nice to see you.
Good to see you. Just want to let you know we are live on Zoom. And so we are, the public can see and hear us at this time. We do not have a quorum yet. We need one more for a quorum. Oh,
Okay.
hold on. We just have Commissioner Avila join us. And 1, 2, 3, 4. You want to start the meeting? Let me know.
I think we ought to. Let me just first thank Dr. Morhaime for being here all the way from Maryland. We are honored to have you, and we're looking forward to having you present to us shortly. May we have actually officially today's the November 14th LA City Health Commission meeting. May we have a roll call, please?
Yes, Commissioner Avila,
Present.
Commissioner Chapa,
Present.
Commissioner Estradas. I do not see Commissioner Estradas here yet. Commissioner Grimmig,
Present.
Commissioner Hisarick,
Present.
Commissioner Cato. I do not see Commissioner Cato. He has joined us yet. Commissioner Kalfani, I believe, is in the public panel. Commissioner Kalfani, if you can join us using the link or the phone number listed under the panelists in the email sent to you, and I will email you as well. Commissioner Lemus, I do not believe has joined us. Commissioner Mandel.
Present.
Commissioner Osi has let me know that she will not be able to join us tonight. Commissioner Pack, I do not see Commissioner Pack. Commissioner Shannon,
Present.
Commissioner Sirota.
Present.
That is we have a quorum, 7 members present.
Excellent. Thank you very much. Is there anybody from the neighborhood council in the waiting area? Seeing none.
Commission President, I'm sorry, correction, there are 8 members present.
Okay, thank you very much. Anybody in the neighborhood council waiting area? Seeing none, we should move on to, there's a motion for the AB 361. Vice President Grimmig, were you going to make a motion?
Yes, I move that the Los Angeles City Health Commission determine in accordance with AB 361, Section 3E3, that this legislative body has reconsidered the circumstance of the state of emergency and that the state of emergency continues to directly impact the ability of the members to meet safely in person, and/or state or local officials continue to impose or recommend measures to promote social distancing.
Do we have a second for the motion on the floor?
I'll second it. Yes, sir.
Thank you. Any comment from the commissioners, discussion, or questions regarding the motion on the floor? Seeing none, could we have a vote on the AB 361 motion, please?
Yes, Commissioner Avila,
Yes.
Commissioner Chapa,
Dr. Chapa?
Yeah.
Commissioner Estradas, I do not believe has joined us yet. No, she has not. Commissioner Grimmig,
Yes,
Commissioner Hisarick,
Yes.
Commissioner Cato has also not joined us yet. Commissioner Kalfani, if you can email me your response. Commissioner Lemus is absent. Commissioner Mandel.
Agreed.
Commissioner Osi is absent. Commissioner Pack is absent. Commissioner Shannon.
Yes.
Commissioner Sirota.
Yes.
That motion carries.
Excellent, thank you. We're open for public comment. Is there anybody in the waiting area for public comment?
Hi, President Mandel. There are currently no speakers waiting to make public comment.
Excellent, thank you. Please let me know if any join. If not, then we're thrilled to move on to our speaker for today, which is Dr. Dan Morhaim, who is a practicing emergency room physician and a former House of Delegate for Maryland from, if I remember, from like the 90s until 2015, wrote numerous legislation improving the healthcare for the people of the state of Maryland. has written numerous books, or at least 2 books, is an expert on numerous issues, including hospice care, death and dying, as well as geriatric care. In addition, on the topic that he's going to educate us about today, I had the pleasure of hearing this lecture and was thrilled, and I am honored, Dr. Morhaime, that you agreed to present to the people of the city of Los Angeles. Dr. Morhaime is a individual who went to Fairfax High School and grew up not too far from where I'm sitting right now, and has been a lecturer and associate professor at the Johns Hopkins University School of Public Health, and somebody who does clinical medicine, education of medicine, and educating the people of the state of Maryland about best practices, and actually passing bills and laws to improve the quality of healthcare. So with that, Dr. Morhaime, the floor and screens are yours.
Well, thank you very much. It's an honor to be with all of you. Yes, I was born and raised in Los Angeles, Rosewood Elementary, Bancroft Junior High, Fairfax High School, University of California, got into medical school in New York City, came back and did my residency at Cedars-Sinai, UCLA, spent a lot of time at Harbor General Hospital in that emergency room, and then worked in Lancaster, California, and Santa Cruz before moving to Maryland, because that's where my wife is from and she has a big family. And I became an emergency department chair for 13 years and got elected to the state legislature in 1994. First session was 1995, and served for 24 years in the General Assembly. And the way it works in Maryland is 3 months. We're not full-time like California, 3 months a year, winter months. It's legislative session. The other 8 months, we all return to civilian life. And there's a broad variety of people who work in a citizen legislature. So my perspective is based on my years in emergency medicine, primarily, and I will now go to share screen. But I also want to thank Ms. Moreno and Lauren Yen and all your staff for helping me put this slideshow together. A little bit more California twist, but there's still a lot of Maryland in it, and for just coordinating all the efforts to be able to be with you tonight. So. And I'll be in Los Angeles in December. Hope to see you maybe in person. Come to one of your meetings. So let me go to share screen. And so this is my perspective. The book I wrote, Better End, about end of life care, endorsed by some prominent people. And let's see here. And so there's the statistics, more overdose deaths than ever before. And you have all these slides, so I will not read them all to you because you're all literate. But there's a big lag in data and it continues to increase. But you see here, I think we went out of, nope, good. And so, and it's worsening. And tremendous number of Americans are suffering from some degree of substance abuse. So, but first, let's back up a little bit and acknowledge that humans want to change their mood. We all want to do that. And different cultures have different ways of doing it, but there's usually frameworks around it. So people have been using substances as long as there's been substances in people, thousands of years. This is hieroglyphic showing wine, and back in the Egyptian time, here's cannabis being used. So this is something that we just ought to acknowledge as part of humanity. The question is, how do we manage it well? But let's jump forward to modern times. Many of you will recognize President Nixon, and the man who's to our left, his right, is John Ehrlichman, who went to jail for Watergate. This is when the modern 1970 war on drugs began. Now, let me be clear, I'm not for substance abuse, but where the situation we're at is we have a drug policy that is really failing in every respect. It's hard, we're hardly in a position to say after 50 years of this, we're ready to have a ticker tape parade down Main Street. We've lick the drug problem, just the opposite. But in an interview in Harper's Magazine, he really came clean about how this war on drugs started. And this one we'll read a little bit. The Nixon White House had two enemies, the anti-war left and Black people. We knew we couldn't make it illegal to be either against war and Blacks, but by getting the public to associate the hippies with marijuana and Blacks with heroin, and then criminalizing both heavily, we could disrupt those communities. We could break up their leaders, raid their homes, break up their meetings, and so on. And did we know we were lying about the drugs? Of course we did. What I'm going to try to suggest to you is there's policies behind all of this. We often see substance abuse or persons with substance abuse disorders as individuals with moral or failings, maybe genetic problems or some bad behavioral choices. But actually, there's a policy issue that goes on in boardrooms, in governments, and in regulatory schemes. And I want you to, that's going to be the focus of my talk, because you're a policy-making body and you can change some of these policies. So that was then came the Reagan war on drugs, and we spend money on what we value. We say we do at any rate, but as you can see, these expenditures under the Reagan years, the war on drugs spending went up a lot, but drug abuse spending went down. And so these policies, the Nixon policy, Holman policy, actually worked. And to be bipartisan about it, I was a Democrat. I am a Democrat, by the way. But Clinton wanted to be tough on crime as well. And so look at this thing, that policy here that went into effect, public housing. So a person trying to reenter wants to move back in their family. That entire family would have to be denied or removed from public housing. So making reentry very difficult. To some degree, this obviously fuels homeless crisis, because if you can't come back to home, where are you going to go? And of course, now you're saddled with a drug conviction, which makes the doors to employment, housing, credit, education closed, but keeps them open for going into worse behaviors. There was another policy, the disparate cocaine powder versus crack cocaine. Let's sort of flash back to the late 60s, 70s, 80s. Powder cocaine was kind of the hip drug, but crack cocaine, essentially the same drug, was more in the Black community rather than sort of a jet-setting white community, and had a 5-year mandatory minimum sentence for small amounts. Look at this disparity, 100 to 1. And all these policies worked. Drug convictions went up, and substantially. We filled jails. We created the jail industrial complex, which is not only the prisons, but all the attendant issues that go with that, home arrest and so on. And so federal prisons filled up with folks, and 50% in federal prisons during life with parole are drug offenses, and 80% are people of color. Now, let me distinguish the person who is the simple user of drugs from people who commit violent crimes about drugs. When I was in the legislature, I was I put in bills to turn simple possession from a criminal to a civil offense. At the same time, after I got elected, I moved to a level 2 trauma center in the middle of Baltimore City, where I worked for 25 years and I'm still on staff. So you can imagine what kind of things I saw. And I took a harsher view of those who committed violent crimes and were major dealers. But this is really a summary from Michelle Alexander's excellent book. The war on drugs was waged exclusively against poor people, and they were stigmatized for life and denied the right to vote. It was just a few years ago in Maryland that we allowed people who had committed felonies and were then out of jail to be able to vote. So they were barred from all these benefits and voting. And when people can't vote, don't feel part of society, it makes them even more antisocial than they're already behaving. But let me turn to another expert on the war on drugs. You may recognize Joaquin Guzman, El Chapo. And he was asked, why do you deal drugs? And he said, well, why do you take them? If there was no consumption, there would be no sales. And this is the way out for him. And he says there at the bottom, I supply more heroin and drugs than anybody, and have a fleet of submarines, airplanes, trucks, and boats. These drugs are not carried in, people crossing borders with a backpack. This is industrial scale business. And way back, I also volunteered at a homeless clinic for 3 years in downtown Baltimore and took care of a guy who was a major dealer. In fact, I asked all my patients, they didn't know I was in politics or even interested in this issue. When I was sewing a laceration or listening to their lungs or whatever, I'd ask them about their lives, and I would say, how'd you get started? And often it was some other person encouraged them to start taking hard drugs. Where do you get, how much does it cost? $50 to $100 a day. How do you get the money? Well, petty crime, major crime, dealing, prostitution, and so on. But this one guy, he'd been in jail for 25 years, and it turned out in our conversation that he was a major dealer. And I asked him about how that all worked. He told me all the operation. I said, just me and you in the room. I'm not the police. I'm not reporting anything. And, you know, duffel bags full of drugs would come into a warehouse where people with no clothes on, so they couldn't take any away, would break it down into small packages, and then it would be distributed on the street. It was a major business. He had panelist white vans driving around, and then all the cash transactions would come back to another place where the money was collected and then laundered, literally laundered as well as financially laundered. And so I asked him, what were you making? I mean, what were you making? He said, $25,000 a week tax-free. That was in $1990. I said, where's the money now? He said, well, my family's living comfortable. But he went into jail when he was 28. He was out when I was seeing him in the 50s. He was 50-something years old, and he needed a physical exam to get into a halfway house. And so I asked him if it was worth it. He said, I don't know, but it was the only way. I got a petty arrest when I was young, and all these doors closed, and this was the way I could make a living. And he was should have been a very savvy businessman, but he wasn't. And he should have been a savvy businessman and a productive thing, not a destructive one. So here's even more on the industrial scale of the delivery of drugs. Really an amazing business, delivering all this stuff from Asia, from south of the border to really every street corner in the United States. And some of our favorite enemies like Taliban, they know where the opioid production is. And so they ship it to us, and then we send the money back to them. And then that's not a very, we ship them a lot of money, and I'll get into that in a minute. But it continues. Now we have fentanyl, which has the advantage from a dealer's point of view of being way more concentrated. And so it continues to crop up throughout the United States. And as long as we're consuming, a steady supply of new drugs will be developed and sold. I mean, those of you who had enough chemistry, you know, you can always change a molecule with a little this and a little that, and then you got a new one that hasn't yet been declared illegal or has found some other way to be synthesized. And we see that all the time, and it's just going to continue and continue to happen until we really get to the heart of the problem. We see these drug busts like this with the guns and the drugs and the money, but that's never really solves the problem. Somebody else takes the place and just have another drug bust. But let's look at the big business side of this. So it's a huge financial empire for those in the dealing drugs. It's also, this is Forbes magazine. This is not some hippy dippy magazine here. That points out that even after fines and prosecution, some well-known banks are all involved in moving drugs for suspected criminals. In fact, what I've also learned from some of the conversations I've had with guys who are major dealers is they put the money into metal cases that are exactly designed to slide into teller windows through the opening, just the maximum amount of cash they can shove through at a time. So, and then of course the money is laundered into in entertainment, real estate, and other industries. The guy I took care of was he owned a chain of coin laundromats as well as a lot of real estate. Now, one of the challenges of this whole deal is the number of patients that came through the ER. Virtually almost every, I'd say maybe every, I want to say every, but almost every person with substance use disorder sooner or later ends up in the ER for one thing or another at all hours of the day at night. And we did a study way back when, this was before Medicaid became more available. And we looked at a couple hundred charts, and we determined that people without insurance, about 80% were there for substance abuse. But here's the problem. When I do a final diagnosis in the emergency room, I put the final diagnosis, but not the substance abuse part, or at least I noticed this in the past for many years, and this is the standard, as the underlying etiology, the origin of the problem. So somebody could come in with an abscess. Was it from shooting drugs, or they skinned their knee and it got infected? Someone could come in with a laceration. Was it breaking a window to steal something in a house, or was it because they were, slipped and cut their arm or had an accident in the kitchen? The final diagnosis will say abscess. The final diagnosis will say laceration. That's what gets coded, C-O-D-E-D, into the medical record, and that's the counting. So when we went back and we looked at all these charts, we could see evidence that a lot of this was substance abuse. Intravenous drug abuse, IBDA would be in the chart, needle tracks would be in the chart, other signs, positive drug screens. But since they weren't the driving thing that brought the person to the emergency room as the primary complaint, they tend not to get coded. And so we grossly underestimate that aspect, which is why one of the policy changes I'd like to see is, and we're doing a little bit now in Maryland, is more focus on having treatment in emergency rooms available all the time. But let's use our own numbers here in Metro Baltimore, and I'll get to Los Angeles in a second, but these are numbers I can pretty much vouch for. So we have daily users 15 to 60,000. Cost per day, I always ask how much do you pay for drugs? And this is 365 days a year. When Katrina hit New Orleans, the substance abuse people were raiding pharmacies. When you multiply it out, and we're just a little state, we could fit into a corner of LA County, 30,000 users, say on average, times $50 a day, times 365 days a year is almost $550 million. And that's just the money to buy the drugs. Doesn't all the other societal healthcare, family disruption, all the other costs are not included. Do this math for Los Angeles. And we have some rough numbers that I'll share with you in a minute. I also tried to connect. So this is a lot of money. And where does this end up? It ends up in overseas at drug cartels and terrorist organizations. So, and just figure out what this would be nationally. It's in the billions. People flee when life is really bad. They don't tend to pick up when life is good or even tolerable. So lots of people are fleeing from countries south of the border because things are terrible. They're leaving their homes, language, culture, families to take a walk across 1,000 miles of desert and all the risks. The two circumstances of the war on drugs and the pressure at the border may appear to be disconnected, but both are a direct result of the failed policy known as the war on drugs. If we could decrease our drug use, there would be less money going into narco-terrorism south of the border and elsewhere in the world, and maybe more money going into productive economic activity. The connection between drugs and crime, I asked this question in a hearing, and one can look it up, it's on the record. Baltimore County is this nice suburban county. My state's attorney said upwards of 85%. Baltimore City, 90% of crime. 85, 90% of crime. Why don't we just deal with the drug issue? It's not just up to police. It's up to us in the public health sphere and in policy making to begin to confront this particular connection. And so when I was campaigning for re-election, and I was elected 6 times, and I had to win primaries and general elections. Mine was not a gimme Democratic district. I pointed out the crime connection and tried to develop support for substance abuse treatment as a crime reduction policy. So the cost is astonishing, trillions of dollars, and it's probably even more than that. But let's not forget this slide and the one after. These are all people. They're mothers and fathers, sisters and brothers, sons and daughters that are dying. And all the statistics really boil down to individual people. Let me jump over to the pain issue. And so I will go into this discussion, and you're probably, because most of you are medically oriented, are very familiar with this. So this is more of a slide for the general public. But once you work through the basic 4, you end up some topical treatments, medical cannabis, and others. So we do need to treat pain, but prescription drug monitoring program, as we call it, cures, as you call it in California, is useful, but dealers, of course, don't use it. But let's look at the role of big pharma. So somewhere in the 1998 to 2003 period of time, a series of bills suddenly started being introduced by very well-meaning legislators in the Maryland General Assembly about acute pain. And the implication was that doctors and nurses were not treating pain. And these are just some of the samples of the bills. And now I was working as an ER doctor. We didn't let people writhe in pain. Our nurses were sympathetic. If somebody had a kidney stone or a broken arm, we took care of it. And I knew this was just nonsense. I didn't realize the full implications until a little bit later, as you'll see. But bill after bill after bill kept being emitted, not only in Maryland, throughout the United States. As a state legislator, I was involved with the National Conference of State Legislatures, talked to my colleagues. This was going on throughout the country at this time period. Pain is the 5th vital sign. Nurses asking about pain. Happy faces, frowny faces, very unhappy faces had to be circled on charts. And if somebody wasn't treating it, there would be problems, as you will see. And so here's yet another pain bill. Now, I had a tough problem being the only physician in the legislature at the time. I wanted to defeat these bills, and I was able to. And these were all really good legislators. I mean, I know them all. but not appear like the cold-hearted, mean doctor. It was tough. Here is a sign-up sheet from one of our legislative hearings, and that first name, which you can't read, came from the American Pain Foundation, and the Maryland Pain Initiative was the second one. I remember this lobbyist very well. Charming, good-looking guy. The woman below him in Maryland Pain Initiative, also charming, articulate. And they made such a strong case for all these pain bills. And people like him were fanned out in every state legislature throughout the country. They were showing up. And this was part of a plan. Only later did we learn out that both these organizations were funded by Purdue Pharmaceuticals, and what we sometimes call AstroTurf as opposed to grassroots campaigning. It's really it's all made up, all a fiction. We were taking care of people with pain. You had similar events in California. I didn't have much chance to research all the details, but here's some California bills. Again, well-meaning, but not really essentially germane to everything. And I have these are bills that you can look up, and there are probably more, but I'd like to thank your staff for getting these to my attention. Now let's look at Los Angeles. 750,000 people approximately in LA with substance abuse disorder. And from your reports, about 35,000 people, accounting for 50,000 treatments. That is a pretty small amount of people, given the denominator of the problem. The numerator here is pretty small. And as Dr. Mandel pointed out, thank you, Dr. Mandel, said tax report FY 1920. Obviously, this is not 1920, it was more 2019. But anyway, that's not my typo. And here they did it again. But this gives you a strong sense of what the issues are. Now, what if we could get in my state or in your county, say, let's use your county, 100,000 people being treated, or 300,000, not all of them. It's, difficult. Think how much overnight, a lot of the issues of crime and substance abuse, homelessness would be decompressed, not solved. Nobody's going to turn them all into sober tax-paying citizens overnight, but at least the harmful behaviors they're doing, where they're getting the money, and encouraging other people to take drugs, because then they become dealers and they've got the built-in clientele. Breaking and entering, robberies, all that other stuff, at least would start to be decreased overnight. But let me go on a little bit to our own state, and I didn't have a chance to review your Maryland board, California board. I'm licensed in California and have been since I did my residency, so I just didn't get a chance to get to that. But here we had from the Maryland Board of Physicians, the entity that controlled whether I work or not, had a free line they set up here in 1998. And that line went to, that phone number here, went to Purdue Pharmaceutical Drug Rep. And what do you think they sent to you? They said, these drugs are fine. Inadequate pain control because of physician reluctance to use medications such as morphine. What's the flip of that? The flip side of that is give more morphine. And so physicians started to do that. And here was this doctor who, unrestricted grant from Purdue Pharmaceutical Company, who went around, did grand rounds, and at every hospital, and we all had to go hear him. And I remember one of his presentations, and somebody asked him, is OxyContin addictive? And his answer was, well, the pain soaks up the OxyContin. I kind of blew my mind at that point, and I knew anyways this was all nonsense, but I didn't fully appreciate the whole campaign that was taking place. It wasn't bad enough they did it in March 1998. They had to do it again in fall of 1998. And so this became a drumbeat that every clinician, physician, nurse, physician's assistant, social worker, pharmacist, had to start paying attention. And the Joint Commission weighed in on it. In 2000, they had new standards. Again, for those of us who are practicing at the time, and for those of your physicians or nurses or other clinicians, ask yourself, if you were back in the year 1998 to 2002, was this really happening? Were people really being allowed to writhe around in pain? No. So the Joint Commission, which, as you know, is the entity that allows hospitals to stay open, and for all of us that are hospital-based to work, here was their, right out of their newsletter. Pain is the fifth vital sign. You start hearing that all the time. And according to the Wall Street Journal, the Joint Commission went so far as to publish a guideline sponsored by Purdue Pharmaceuticals. And this is what was put out. There is no evidence that addiction is a significant issue in persons are giving opioids for pain control. They eventually backtracked it, kind of a lame backtrack in 2016, but here's where a lot of the damage got done. This was drumbeat every place you turned. I talked to surgeons who, let me say, let's jump into Press Ganey, but I talked to surgeons who said, you know, somebody would have some kind of surgery, hernia, I give them 5 oxycodone. But after all of this, I started prescribing 20, 30, 40. That's where a lot of this came from, because they didn't want to be called in on Press Ganey, which is a national hospital survey company. For those of you who know about Press Ganey, has a lot of clout, and you don't want to get a bad satisfaction score from them, because it also relates to reimbursement. So administrators started holding us all responsible, withholding bonuses. And so physicians therefore feel pressured to prescribe opioids when patients requested them, despite their reservations. So this is, you know, the hospital regulatory system. This is putting pressure on all the clinicians. And so here's some more studies that again point out the continuing problems of Press Ganey's flawed metrics for emergency department setting. And this was just fairly terrible, actually. But this is how these were policy decisions made in corporate boardrooms, in regulatory organizations. These aren't random events. These were thought through. As you know, like in your own group here, you don't just make a snap policy decision. You discuss it. It goes through a process. And that's what happened. Fortunately, more recently, physicians have been able to move the pendulum back a little more towards the middle. One of the problems, though, is there are some people who really do need regular narcotic medications for one reason or another. Not a lot, but you know, they're having trouble getting it. So they're often now going out to the street. And the people that were hooked because of all these policies between 1998 to 2015, you know, have to go out to the street also, and all the social problems that are attendants with that. Let's look at the drug companies. They had a little role in it too. I'm sure you're aware of these, but these amounts that they had to pay sound like a lot of money to you and me. But you know, they're rounding errors. None of these companies went out of business. Of course, they had those deals where they don't admit any guilt, but they distributed large amounts of pain medications. And then the Sackler family. I had to update the slides. This one's just November 2nd, a few days ago. They each agreement, CVS and Walgreens, $5 billion each to settle lawsuits. I hope the money that's going to the states will be used for substance abuse treatment. There's a whole range of other issues that I will just touch on very briefly, but the prison industrial complex, the militarization of police. In smaller towns, a lot of police make their money on drug busts income, seizing property, sometimes appropriately, sometimes not. So, but let's look at Portugal. They decriminalized all drugs, and people said, oh, it's going to be a haven for everybody in Europe. It's going to come to Portugal. Well, whether they did or didn't, they made it a huge public health expense, and all the problems that we would like to see go down went down. Less drug use, less needles on the street, way less crime, less overdose deaths, and so on. You know, our numbers are going the opposite direction. Canada and now Rhode Island and New York City have proved that safe consumption facilities work. Unfortunately, Governor Newsom did veto those bills that the legislature passed, but maybe you should try again. I was giving a talk on this a few weeks ago, and somebody from the audience said, don't call them supervised consumption facilities, call them treatment entry sites. And that's because when people go to these places, not only are there, you know, no overdose deaths, so that's the first thing. People don't die because there's always a rescuer present, but they much less spread of disease, fewer needles on the street, less crime. But then they start getting connected and take advantage of the treatments that are available. And we're all paying for it, whether immediately connected or not. Out in my district is a very nice suburban district. Business people say my health insurance premiums are going up. Why? And I say, because, you know, we're spending so much money dealing with the various outfall of substance abuse. Every time you read in the newspaper, a gunshot wound, overwhelmingly, it's a drug deal gone bad more than any other thing. And so it becomes uncompensated healthcare that it gets added to the burden of healthcare costs. So I really think the key question boils down to really this, that we don't want to confront and don't ask. Why are so many Americans across all demographics using drugs? Why this level of despair? And the first part, this is my editorial comment, our focus on material wealth and distractions, daily stress, and so on, isn't fulfilling. And as Kathy Park Hong noted, proving my self-worth by expanding my net worth until I vanish. And the opposite of addiction isn't just sobriety, it's connection. I mean, we all have stress in our lives. I have stress in my life, but because I have, fortunately, a pretty good family life and have a job and some meaning, I'm not turning to substance abuse. But when I talk to the patients, so many of my patients, they tell me about their lives. The dialogue in my head is, gee, if that was my life, I might be using substances too. I'm not that strong. I mean, they have some pretty horrible situations that people grow up in. And so it becomes generational. And not many, some people can get out of it, but many can't, or they get stuck with a, petty crime conviction that then tracks them for the rest of their lives. Now, this is interesting. You go back to Johann Hari, because this is where I got some of this information. Just as a talking point, we probably all are familiar with the iconic study, The Rat in the Cage, and the rat has two levers. One is for drugs and the other is for food. And we're told that the rat keeps pushing the drug lever until it dies, or doesn't push the food lever till it starves because it's busy taking drugs. Therefore, all drugs are bad and addicting and so on. Bruce Alexander here, and there's a whole series of studies that he did. He created something called Rat Park. Everything that rats like, other rats, rat sex, cheese, tunnels, games, whatever rats wanted, it was there. And the lever was there as well. The drug lever was there. Very few rats use the drug lever. This did not get the attention that the iconic other study did. And so, his conclusion, the opposite of addiction is not just sobriety, it's connection and community. Isn't that what keeps a lot of us moving forward, that we have some meaning in our lives? So we keep doing the same thing. Prohibition didn't end alcoholism, but it did reduce crime. And all the data points are going in the wrong direction. We just ought to recognize it and say, when is this policy going to be changed? It's 50 plus years. Again, I'm not for substance abuse. I don't use them personally. I don't recommend them except in limited clinical conditions. But it's destroying our country from the inside while we're shipping literally billions of dollars who would destroy us from the outside and creating all kinds of social and personal havoc. So here's some of the new policies that I would recommend. One that I didn't have, we're now able to do in Maryland, is called SBIRT, which is Screening, Brief Intervention, Referral, and Treatment. It's not hard when you're in an emergency room and people with substance abuse disorders come in, whether they're there for something minor, but very few are in there just, I take drugs, so treat me. It's some medical or social or mental health condition. I don't have the time or the expertise to sit and talk with them about it. And for many years, all I could do is give them a piece of paper with a bunch of phone numbers on it and hope they call someplace. And, it's very difficult to get into treatment. What we have now is peer review, peer support folks who have had substance abuse, are now in recovery, have done a formal training program. And I could say to a patient, gee, I see that the reason you're here for this laceration and the pneumonia you have is from, related to your substance abuse. Let me get you in touch with this person, our peer counselor over here. And they go off to a room and talk for a couple of hours and really try to get to what's going to work for this person. There is no treatment dogma. Everything is individual. Some person may do very well with methadone. Somebody else may need to, do very well with a faith abstinence and a faith-based position. Others may be different things at different times. But if you can get these people into treatment, and this has to be available 24 hours, 7 days a week. And we're actually able to do that most of the time in Maryland now at most of the big hospitals. So maybe 2 to 6 in the morning, nobody's there, but you can always hold people over till 6 in the morning when the counselor comes back in. The job of an addiction treatment counselor really is underappreciated and under-rewarded. And the peer review counselors have done a great job, not just giving people a piece of paper and saying, I hope you call. Look, regular patients, I give them a piece of paper and hope they call. They often don't, but you can imagine a person who a couple hours later is back on the street and thinking about their next hit. They connect them directly with treatment programs and get them in. And it doesn't work perfectly every time, nothing does, but it's made a huge difference for us. Back in 1998 was my first substance abuse treatment bill that I introduced, mainly because I was just seeing what my patients were coming in with. 3 months a year, I was January to early April, I was in the legislative session, then I'd go back and work ER shifts for the next 8 months and then come back the following year, legislative session with new ideas about what was needed based on what I was seeing in the emergency room. I'll skip this. Supervised consumption facilities. This is the Journal of the American Medical Association from this year. Again, I hope maybe you can do a pilot program in Los Angeles City, even if the state law didn't pass. Maybe you can do a pilot program. But this is, again, Journal of the American Medical Association saying that it's helpful. Not to be outdone, so the New England Journal of Medicine. These are, our national peer-reviewed, most prominent medical journals. So they finally come around on this subject. It took a long time. I and others have been goading them, but this is major medical literature. This is not, crazy crackpot ideas. This is as solid as it gets. I just want to digress to 2 other bills that did pass this last Maryland General Assembly session. They're not exactly on this topic, but it's pretty close. These are bills that I put in a few years ago that finally passed after I left. One is that advanced care plans, advanced directive information should be available in the electronic health record, just like all other information is. This came out of me doing a lot of codes in the emergency room that I didn't really think I should be doing, but had to. And then what about the other, the non-CDS drugs? It's weird in a way that I can look up Schedule 2 through 5 medications that patient may have, but what about the other 99.5%? That ought to be just as readily available, and not just locally. It should be, regionally, nationally, even because people travel. People go all over, and people come to the emergency room and say, my blood pressure is up, I can't remember what I took, or my doctor gave me an antibiotic, my wound's not getting better. Well, I like to know what those medicines are. Many years ago, when I was a young doc, some of this wasn't so hard. If somebody said, I'm on an anticoagulant, I could say, is it a pill, which would be aspirin, or do you get a blood test, which would be Coumadin, warfarin? Now there's many anticoagulants, and working in a trauma center, there are times when we need to reverse anticoagulation. We can't stop hemorrhage any other way. But now with the new anticoagulants, I got to know what it is. I can't just pull something, can't guess. Likewise with diabetes. Way back when I was a young doctor, there was insulin, you're taking a shot, or you take a pill, metformin. Now there's dozens of diabetic medicines, and that's great, but I got to know what they are, and people, we shouldn't guess. So we have passed legislation for both of these, and 5 to 10% of hospitalizations are medication related. So these are the references that I've used, but most of this is actually my own experience as a clinician. So, really what it boils down to is, yes, there's individual decision-making that, leads to some of this and so forth, but a lot of it are the societal decisions, decisions made in boardrooms, in regulatory agencies, and that's your policy-making group. We're all policymakers here to some degree or another. This is where we can begin to turn it around. Let's see if we can change our policies to decompress this problem, which really drives so much in our culture and so much in our society. And I think if we can do that, it'd be a big step forward. My last anecdote, when I was first elected, 1994, my first legislation session was 1995, and there was a bill in Maryland that was the most intensely lobbied bill of all. I mean, I just couldn't walk down the hall without somebody coming up to me and saying, Delegate Morhaim, you got to vote for this bill. It's the most important healthcare bill, possible, and it'll save lives. And then, if somebody else would come up to me and say, you got to vote against this bill, it will destroy the Maryland economy and put thousands of people out of work. This was heavily debated. What was the bill? It was to ban smoking in restaurants. Smoking in restaurants. Well, we finally passed it. It took 10 years to ban smoking in bars after that in Maryland. Now we look back and say, what was the fuss about? I mean, what were we fighting about? And we can see that with other issues in our state, maybe in yours, marriage equality might be one, and others, sometimes still being litigated. But I know that by continuing education, conversation, we can change policies on the drug wars. They're not, haven't serviced us in any way for the last 50 years. It's time to turn it around. So thank you very much. And I'm open for questions, comments, or personal attacks, whatever you like.
Thank you for the wonderful presentation. I had told the commission that I had seen this very similar talk and knew you were tremendous and knew that the people of Los Angeles and the commission itself would want to be informed and educated by you. And I'm really thrilled that we had you come today. You talk about a story about a patient that you were taking care of in the emergency room. I actually remember as a third-year medical student admitting a gentleman who had a bacterial endocarditis. For the lay public watching this, it's infection of his heart that he had gotten from skin popping. Basically, he had destroyed all his veins from injecting, couldn't find the vein that would really take a needle anymore. So he would just kind of push combination of speedballs, mixtures of heroin and amphetamine into his skin to get some of it absorbed into his body so he'd be high. But unfortunately, when you start doing that, you end up with skin abscesses, which then get infected, and the infections get into your bloodstream, and it sits in your heart, causes the valves to become infected, and people die from that unless they're given very powerful antibiotics intravenously, which I ended up managing him for a long period of time. But here I am putting a big, what's called a central line underneath his clavicle bone. And as I'm doing it, I've developed this good relationship with this guy. So I said to him, so about how much are you using a day? And he said, $400 a day. And this was, 1979. I was pretty good with math, and I quickly calculated that was over $140,000 a year. And I said, what do you do for a living? That's a lot of money to be coming up with, $140,000 for your habit. And he looked at me with this very serious look, and he says, I guess they admit stupid people into medical school because there's no way you can make $140,000 excess cash legitimately. And I'm not about to tell you how I make my money, but I can tell you for one thing, look the size of me, nobody stops me from doing whatever I want to do, which taught me a couple lessons, one of which is that crime is directly related to chemical dependency, that we as a society have a responsibility to if you want safer streets to address the crime problem, we really need to address chemical dependency. If here in Los Angeles we want to address the homeless problem, we know that the numbers are directly related to chemical dependency, and dramatically would be less if we would have a good drug policy.
Yeah. There's a lot of petty theft never gets reported either. Grandma's clock radio disappears. That's not getting called into the police. And stuff that's taken is also not sold at face value. It's sold on the street for the TV they might steal from you, or for your phone goes for way less than its market. So yeah, it feeds all of that stuff. And I've asked plenty of the patients that I took care of where they get their money. And one of the things is that they want, if I was a substance user, I would hear my friends on this call, I would try to get you hooked because you would buy from me. I would make the marginal difference to support my own habit. So every time you pull somebody out of substance abuse into treatment, you're actually not only helping them, you have a little bit of a chance of reducing new people getting hooked as well. So it goes deeper. But the crime issue is homelessness and the mental health and all the other stuff that spins out of this, and yet the policies that you could change. So when I put in the bill to decriminalize possession of all drugs, simple possession, not dealing, simple possession, and I got some pretty tough questions in the bill hearing. So Delegate Moorheim, you want to decriminalize? Yeah, but the bill said you would get a ticket in effect, a civil penalty with a $20 fine and referral to treatment. The second time you'd pay a $50 fine and referral to, and the third time you'd get into the criminal justice system, just to try to give people contact with the criminal justice system. The legal system sometimes is a motivation to get them into treatment, but different things work for different people.
Was that bill?
Criminalizing people.
I was going to say, was that bill somewhat successful or implementation.
Not at all. No, not at all. But it's continued to be picked up by legislators after I left my 24 years in office. That felt like enough, who are doing it. And there's actually now a work group to work on the decriminalization. I don't want to excuse the violent behavior or the other things. And by the way, other things that we'd see in the emergency room, there's a technique of enforcing the drug wars, with guns, and you could shoot people in the head, but it's also very popular in some areas to aim for the navel and shoot them there. And what happens is sever their spinal cords. If you go into some of the rougher neighborhoods in my town, in any town, I was just in Philadelphia campaigning for some of the candidates, you see these little cohorts of young men in wheelchairs. They often come to the emergency room with skin breakdown and urinary tract infections. This was all drug wars. Over the years, they're coming. The chart doesn't say, got a disagreement about a corner and this guy shot him in the abdomen, in the belly, to send a stronger message than shooting him in the head. But it's, thousands of dollars of healthcare costs. Just doesn't get tagged back. That's what you see in the emergency room.
In the southeast portion of the People's Republic of China, where a significant amount of poppies from Thailand through going towards Afghanistan or vice versa, both directions. There's over 150,000 police officers who've been shot in the stomach for the same reason, purposely or shot directly into the spine, as a message to all the other police officers not to stop the drug dealers. One of the reasons why there's such a triangle of drugs moving in both directions.
Well, I talked to the guys who pull in the triggers too, and they told me about how that all happened, and some of it was. I remember one guy took care of. It was in 2009 when the economy was down. He was down in his 50s. He was a truck driver, but in talking with him, I'd say, "Were you ever in jail?" A lot of guys would say, "Oh, I did a 2-spot, like in 2 years, sort of casual, like, did you go out to dinner last night or see a movie? 2-spot." Anyway, he spent about 10 years in jail. He went in when he was 16. He came out 26. I said, 10 years for a 16-year-old. What for? He said, murder. Well, what was happening was he was a little kid, and dealers would give him a gun and $2,000 and say, go kill that guy. And he would wander over and nobody paid attention. He was a little scrawny kid in a t-shirt and shorts, and he'd just pull out the gun and kill him. He said he killed 6 people and got caught for the last one. But because he was a juvenile, he didn't spend more time. He reformed his life. He became a truck driver when the economic downturn hit. I was seeing him at the homeless clinic. But these are the stories that, when you talk to folks, they tell you stuff. I say a couple of hands up, but yeah.
Yeah, I'll go to them in a sec. Your governor-elect, actually, Wes Moore, wrote his first of 3 books, The Other Wes Moore, and he talks about another individual who was a really smart guy who was running a gang in Baltimore by the age of 15. And Governor-elect Moore laments that he feels bad that this poor guy at age 27 serving life imprisonment because this guy was really bright. It takes a lot of leadership and abilities to run a gang by the time you're 15 years old. Very successful guy, had multiple opportunities, unfortunately kept on looking at the revenue he could generate from the drug trade, and nothing could compare to that. So he kept on going back to it. And so the sad aspect of things is here's a situation where some people end up in prison, where other people have an opportunity to reform themselves and be productive members of society. Commissioner Hisrick, your hand was up first.
Let me unmute myself. Thank you. Enjoyed your presentation, the interesting background that you have. You have worked in hospice field, I see. And one of the big issues there, of course, when Cicely Saunders first wrote about it, was that we should allow the use of addictive drugs at the end of life, because pain control and management is the issue. Now, is that in conflict with the concerns that you've raised about addictive substances and so on? I mean, on the one hand, it seems to have worked for her and for the folks that she dealt with, but obviously it's being abused in other circumstances. One of the concerns I have is that hospices, which started out as sort of nonprofit organizations, have now transitioned to become more profit-making organizations, and maybe there's some abuse there, but just, those are just issues that popped into my mind as you were talking.
There's certainly no conflict from my point of view that hospices should have every tool available. And I, couldn't cover every point in this talk, but I did touch on it when I said, physicians have been very reluctant, became more reluctant to prescribe, but it also, in the whole pushback on prescribing narcotics, I did say that also means some people who legitimately deserve them don't get them. In Maryland, we have a different hospice system than you do in California. Here, they're all nonprofits. That doesn't mean they're, so we don't have that pop-up all over the place hospice kind of thing that I've seen when I'm out in
Right.
Los Angeles. But, it's not the drug, it's the context of its use. I mean, if I was holding a bottle here of 20 OxyContin, did I steal it to go sell drugs, or do I have metastatic bone cancer? The drug has no moral standing or ethical thing by itself. It's the context of its use. In one case, not appropriate, in the other case, appropriate. So, I would agree with you. I wouldn't want the backlash of this to affect people who have legitimate needs. On the other hand, that's a smaller population than the rest of the tumult that the drug wars have caused.
The fact that they're all nonprofit hospices, is that a result of legislation in Maryland?
Yes.
That sounds like pretty good legislation.
The legislation and regulatory, every so often they for-profit tries to come in, you have to get a certificate of need, and the nonprofits have addressed a lot of the alleged needs issues very well. So
as you're probably aware,
occasionally
there's been quite a bit of abuse here in the field.
I am aware. There may be one for-profit, but it's very well regulated here. So we have other problems, but that's not one that we have.
Okay, thank you.
Particularly badly, at any rate.
Thank you.
Commissioner Shannon.
I just want to say this was such a fantastic presentation. I'm so glad that you were able to speak to us today. I actually have a question. So the Health Commission has supported sober living centers and a wider distribution of Narcan for opioid overdose. But what we're seeing a lot too is the prevalence of opioids and, particularly fentanyl, which is being, kind of hiding in some of these drugs in our schools, and particularly in our high schools. And I'm wondering if you could maybe speak to that, and whether it makes sense for us to, make sure that Narcan is in high schools, or that parents are carrying Narcan to try to, stop kids from dying, which is happening all over the country right now.
I think you're exactly right. I mean, there's no one silver bullet to deal with all this stuff. So I am definitely for the liberal distribution of Narcan wherever it is. And fentanyl has the problem that it's highly concentrated. So you don't need to have like these big bags, duffel bag full of heroin. A few pills of a couple of handfuls of fentanyl is the morphine equivalent. So it's a very dangerous drug. We're suffering from that issue here. We also have fentanyl test strips now being distributed in Maryland, so a substance abuser could see if there's fentanyl in the drug. But drug dealers are very clever chemists, and the Chinese, where most of the China, where most of the fentanyl comes from at the moment, is they're very clever about packaging and marketing and making pills with pretty colors and all kinds of things. So it is a serious problem. And step one is to not let people die of overdoses, and so Narcan ought to be readily available everywhere, in my opinion. But that's, the deeper issue is why across demographics are so many young people turning to drugs. And I, offered my suggestion that I think it's because many of the core values, and this is my editorial comment, in our society are based on ultimately things that are not fulfilling. Acquisition of material objects and, power, appearance, clothes, they're nice to have, and I like my material objects, but that becomes the driving, paradigm of what makes you successful in society. You're going to fall short, because I think the things that are more satisfying, the work that you all do, connection, community, wherever that is better, but we don't champion those. We pay movie stars lots of money, but we don't pay teachers very well, and so on down the line. And you know, frontline healthcare people, one of the things that I've always championed is, you know, as a frontline health worker in the emergency room at 3 a.m. Now look at the ER clerks; they're like air traffic controllers in chaos. You know, 75,000 visit per year trauma center, and they're making $15 an hour. I mean, those people ought to make $40 an hour, in my opinion. The nurses ought to be making $100 an hour. Our CEOs make, and we have a nonprofit hospital system, are making $4.5, $5, $6 million a year. You can live in Maryland very comfortably on $3 million a year, even $2 million. So yes, Ms. Shannon, I think that's a very good idea, but it's, you know, it's all these things at once have to happen. The change in policies, treatment entry sites, supervised consumption facilities. Maybe that's a policy you can recommend at a pilot level. I see it I see most of my stuff through the focus in the ER, because that's where substance abusers end up. Hospitals ought to be very aggressive in their treatment availability, not just giving people phone numbers, because they're open 24/7. They're usually on bus lines. They have all the other social supports there, and yet we fall short. I mean, I'm thinking if I had a patient that had a complicated OB problem, I could call Dr. Mandel. He would come in. But if somebody had a broken leg, there's something I couldn't manage, I can get an orthopedist or an acute MI, I can get the cardiologist. If somebody with substance abuse comes in, I can say, well, take care of your somatic complaint or whatever. And by the way, I got nothing else left for you. So hopefully our peer review counselors in the emergency room are going to begin to get folks connected, and we're trying to ramp up the treatment resources so people can get to them. But you saw those Los Angeles statistics, 750,000 people with substance abuse disorder, you know, 40,000 are being treated. You make that 3 or 4 or 500,000, I think you'll see some improvements.
Wow, thank you.
In Los Angeles, there used to be almost every major hospital had a detox unit with a holistic treatment. So it was detox, it was mental health, it was medical consultation and the like. And they were extremely beneficial and got excellent results, and were in fact quite profitable for the hospitals. In the late 90s here in Los Angeles, we had our recession a little bit later than you did in the East Coast. But in the late 90s, with the Sustainable Growth Act from coming out of the Balanced Budget Amendment in Congress, hospitals found themselves in situations where Medicaid, or in California, Medi-Cal, was losing a dramatic amount of money and being underpaid for their services. What would happen is, because of EMTALER, they couldn't transfer patients who came in that had Medi-Cal. And so their once very profitable centers ended up being paid and reimbursed at a Medi-Cal reimbursement rate, and 30, 40 days in a treatment center in a hospital ended up losing the hospital's money. So they closed all the centers. So all the major superb, stellar centers in the west side of Los Angeles, and almost every hospital had one. Cedars-Sinai, Century City, UCLA, what is now Olympia Hospital, or was Olympia Hospital until very recently when it went bankrupt. They all had treatment centers that were successful, and they all closed in direct relationship to bad government policy, where there was under reimbursement. So the hospitals lost a significant amount of money, and as a general rule, hospitals don't want to do that. So they close all their centers, unfortunately. How does Portugal handle detox for people who want to? Is it inpatient? Is it outpatient? How do they make it work? Because clearly that's an issue that you can't just legalize things unless you're going to give adequate support for people who want to get sober and maintain sobriety.
First of all, let me say that I think it was actually a California study from way back that showed for every dollar invested in treatment, society saves $7. So it's really a great bang for the buck, cost effective wise, given all the other issues that I tried to touch on in terms of expense. In terms of Portugal specifically, I don't know the details of that. I'll try and research it, but from what I understand, You know, it's just a huge investment in public health, and there is no one treatment plan. It's sort of like if a patient came and said, let's say I found somebody had high blood pressure, what would I treat them with? Well, it depends. How old are they? What's their gender, their race, their family history, what other medicines have underlying disease? You know, there's 20, 30 choices to give. It's the same thing. I think there's a tendency for treatment dogma that I've seen a little bit in the treatment community. So some people may need 3 months, you know, Mountain Manor retreat. You know, other people may benefit because they've got a job and a family, but their use is getting bad, and maybe they could go to outpatient treatment 4 or 5 days a week for an hour or group. Other people methadone or buprenorphine. So it really is an individualized decision. And my sense of what goes on in Portugal is they have a in-depth comprehensive program. And although everybody, you know, predicted every heroin addict and destroy the country would arrive in Europe, would come to Portugal, you know, all their numbers are better. Way fewer substance abusers, way fewer. And then, you know, they had the social network to support people into reentry, as opposed to say, I get out of jail and I have a drug conviction, I go to public housing, but my family can't take me because they'll be kicked out of public housing. I mean, that was our policy for many years. It may still be, for all I know, on this one. So, you know, these are structural decisions that have been made. I assume the drug settlements that I referenced will send some money to California and then to Los Angeles, and you'll have some money maybe to invest in some of these things. We've also had some problems in Maryland at some of the entities that do substance abuse treatment. I think they need to be a little more tightly regulated with outcome measurements and so forth. You know, but again, it's individual, and some people, you know, say abstinence and faith-based is best, and that works for some sliver, you know, some segment of that population, but for others, it just doesn't. And you know, I'd rather people be on methadone for years and they can function and not commit you know, the antisocial behavior and the harmful behaviors to themselves and all the people around them and to society in general. So that's a maintenance approach, but anything that would it's not solving all of it at once, just decompressing every step along the way would make a huge difference. And it's all very doable and all very affordable.
I pray that the monies that come to Sacramento from these settlements filter down to public health. It hasn't been previously what's happened with the tobacco tax money. Most of the money didn't go to public health. And I would hope that this money would be all directed. I'm not so sure that'll happen. It'd be nice to have the city council advocate our state representatives that happen. It's unfortunate that a lot of homeless people have alienated their own families, and some of that's directly related to, unfortunately, their previous drug usage or chemical dependency, where their families have tried repeatedly to help them, but have been either had things stolen or violence that happened within their homes. And so they're not willing to take another chance. And I think that's an area where we have an obligation as society to do social service for the whole entire family. Because as you pointed out in the RAT study, that with community, people have a greater probability of staying sober. Without it, it's not going to happen. Any other commissioner have a statement, question for our distinguished expert? Ms. Moreno.
Yes, thank you, Commission President. I really enjoyed this presentation, and it was interesting because just this morning I was reading this press release from an organization, A New Way of Life, which is a reentry program. And it's founded by this woman, and she talks a little bit about, you know, she basically equates the prison industrial complex to modern day slavery. And she, you know, gives a little information, and she talks about how, you know, when she was incarcerated, and she was punished for grieving the loss of her son in the way that the state found unacceptable. She said she needed help. She lost her son when he was only 5 years old and didn't know how to deal with the grief. And so she self-medicated. She sought comfort from drugs and was incarcerated for the grief management. And so it's very, you know, I just read this today, and this is something that you touched on in this presentation. And so, I think that there are some great organizations in the city who are doing the work of trying to address the needs of folks that are reentering into communities. And the other thing I wanted to just let you know, share with you, is that there is a council file involving the city's case against the drug companies. And that's a council file for the Research Associates, Council File 21-1240, City of Los Angeles versus Purdue Pharma, LP et al. And then Council File 21-1240-S1 is for the opioid settlement trust fund that is being created. So that's just an FYI. You're muted, President Mandel.
Commissioner Shannon, is your hand up from before, or do you have another question?
Commissioner Vaughn raised his hand, I think.
It's up from before.
Okay, thank you. Mr. Vaughn is our LA City attorney. Attorney Vaughn, would you like to make a comment and or discuss?
Yes, I'd like to echo such a tremendous and wonderful presentation. And I love the fact you took it from politics to holistic nature of this, and to talk with Rita. I actually am the city attorney that works on several of the programs in the city for reentry. And what I think at least the city has found with these programs is it takes a holistic approach to helping individuals who are reentering after drug addiction, such as cognitive behavioral therapy, lawyers to help to make sure that their records are expunged from those drug convictions, housing availability, and then any other resources. And I wish we could scale it larger, but currently there are at least several programs in the state of California. They had a proposition called Prop 47 that took low-lying felonies and made them misdemeanors. A lot of those were drug convictions. And then they took the money, and jurisdictions were allowed to have grants to be creative in order to help individuals. So I think the state is doing at least the city of Los Angeles is trying to take the approach that you recommended in your conclusions as to how to help with these individuals coming back into society. So hopefully it can scale larger. But I know, having been also worked for a federal judge some 22 years ago with sentencing guidelines when they were still enacted, and how inequitable they were then, and they were found to not be equitable anymore. I think, it's slow, but hopefully the train is going in the right direction.
Well, thank you both for the nice comments, and Ms. Moreno, thank you for that heartfelt story, because it's always, we have to remember these are all people, at the end of the day, who are facing these issues. And yeah, these are all policies. These were conscious policy decisions, and I faced some of them in the General Assembly, but I'd use that smoking example. Hopefully we'll look back a few years from now and say, well, thanks to the LA City Health Commission, we now have peer review counselors in every emergency room who are well connected with treatment places. We've got attorneys, we've got other things. There's a program here called, I volunteered at a homeless clinic for 3 years, and it changed my thinking on the subject of something called housing first. The idea was, originally we had to get people sort of clean and sober and mental health stuff, because you don't want to put them in an apartment, they'll just destroy it. That was my thinking too, I must confess. But the reality was, when people had even a modest, safe place to live, it made a huge difference in their total attitude and approach. They could get mail. They didn't feel terrorized every night if they were going to be killed or robbed. They could take medications regularly. So I had to change my thinking and support housing earlier in the process, rather than let's hope these people are, like going to be responsible tenants. They're not going to be responsible tenants at the beginning, but so my thinking, you mentioned housing, and so I know LA has a big housing problem. We have a housing problem here, not of your scale, but that's an issue. But those sentencing guidelines were conscious decisions. I mean, legislators voted for them, Congress people voted for them, and just as they are done, they can be undone. So I was the first state, when I put in that bill to turn possession of all drugs from criminal to a civil penalty, simple possession, you got to imagine the hearing. People were, thought I was crazy. I kept putting that bill in, but bit by bit, there's a consensus. In fact, a couple of legislators who were Republican conservatives have called me up and say, well, I want to take a fresh look at that. It just takes time. All these things take time, but you're a policymaking group. Or I guess you make recommendations, I assume. And so I would hope you put a list together here of changing the drug laws, expungement, housing first, supervised consumption facilities, or better now, treatment entry sites. Maybe you can do a pilot program and study it, involve one of your schools of public health on that. Focus on emergency rooms where all substance abusers almost all end up sooner or later. They're already in a healthcare institution, but we're simply not taking care of that problem. And Dr. Mandel, what's the financing that needs to happen to make it in the interest of the institutions to do so, and down the line. So, and Narcan and all of it, it's all has to happen if we're ever going to dig our way out of this mess. It's destroying our country and robbing our treasury and funding terrorists. I mean, it's a disastrous policy.
Our paramedics have expanded so that specifically deal with chemical dependency on the street differently than sending out a whole fire truck. Those pilot projects have been very successful that need to be expanded. Commissioner Shannon, your hand's back up.
Yeah, so thank you for mentioning Housing First. I'm actually the drafter of the Housing First bill for the state of California, which passed in 2016 and was authored by State Senator Holly Mitchell. And yeah, it's so important because I work with our unhoused community here in Los Angeles, and it's so important to get people stable first in housing before you can actually deal with a lot of other issues. So thank you very much for mentioning that. And the Health Commission since 2016 has supported a Housing First model.
Well, that's good to hear. I hope it continues to work. Each one of these points, there's something that could be, further said. Some of the small towns, that's how police survive. I do want to support our police. I mean, I work every shift. There were police in the emergency room, and they endorse me every election, by the way. But, the drug busts, they would seize property and cars. Sometimes it wasn't the dealers, it just happened to be a person. I mean, they finance their offices to some extent, not the big metropolitan ones, but smaller ones around the country do. The prison industrial complex, the amount of money that when people get home detention, they have to pay for the ankle bracelets is another industry. I mean, it goes on and on and on. And a lot of those things become, not only, they become burdensome to the family that's paying for it, which I think some of you have touched on, the family impact, because the prisoners have to pay, or the person with the ankle bracelet has to pay for it. So they get deeper in debt, and then they're more miserable than ever. And so we've got to figure our way out of this one. And I think there's many things that can happen at the same time, all at once, from one end of the spectrum to the other.
Any other commissioners?
Well, I have one request from Ms. Moreno. Please send me your list of, put me on your schedule as a public member so I can know what you're doing and, sit in and, learn from you.
Thank you. We're honored that you would take time from your busy schedule to present to us for your excellent presentation, as well as the fact for staying up fairly late back on the East Coast. One of the blessings of COVID is that we've had the ability to have these meetings so that we can bring world-renowned experts from New Zealand, from the United Kingdom, from Harvard, Mass General, Stanford, and from Johns Hopkins, and from now from Baltimore. So we're thrilled to have you have presented to us. We're really honored that you take time to do
Thank
this.
you. I'm happy to do it.
Thank
Passionate
you.
about this subject, so I will go anywhere, do anything to push this along and keep me posted. I mean, we're all, I certainly don't have all the answers. We're all grasping. So, if you come up with good stuff, tell me. I'd like to share it in my state and region here too.
Excellent. Thank you. Thank you so very much. All right, have a wonderful Thanksgiving. We're thankful for many things, including the fact that you would take time to present to us. Thank you. See, frozen. I think he's frozen. Okay. Moving on to agenda items. Next agenda item is new business. Any ideas for new presentations or discussions from any of the commissioners? As always, please let our research associates know of things you have interest in. We have a couple things we're working on, one of which is our annual report, and also bringing in some other experts to discuss some of the alterations of COVID and some of the genetics of COVID. Mr. Vaughn.
Question regarding research associates. I know we have incredibly stellar, incredibly smart research associates. If someone would want to be a research associate, how would they go about applying for that position? I was approached by a colleague whose daughter goes to Stanford and is an undergrad, but is very interested in being a research associate. So I was wondering whether Sarah can address this, or you, President Mandel, about how one would, the public would go about to apply to be a research associate.
Usually they would send a resume through the city clerk's office that would then be sent to our senior research associates, Sarah and Lauren, initially to research the individual, meet with them virtually to see what their interest is. Would this be a good fit? And then move the individual's name to the leadership of this commission. And we could handle a few other individuals to do work for us.
Thank you, sir.
I'm assuming, Sarah, that nobody else has come into the public comment for this evening.
That is correct. We do not
Excellent.
have anyone.
Well, seeing that and seeing no other information, any other commissioners have a comment? If not, is there a motion for adjournment?
I make a motion to adjourn.
That's Commissioner Sirota.
Second, Hisserick.
Hisserick, second. Any discussion on adjournment? Seeing none. All in favor of adjourning?
Aye.
Aye.
Nobody's abstaining, nobody's opposed. Officially adjourned. Thank you very much for your dedication and volunteering for all the commissioners and to our research associates. Thank you, Mr. Vaughn and Ms. Moreno, as well as all the other city employees who make this available. I want to.
I just want to apologize. I had a little power outage here, came back on.
Okay. We all said great things about you, Dr. Moran. Thank you.
Thank you. Okay.
We're just about adjourned.
It's fine.
I was thanking the city employees and all our research associates for all the volunteer work that they do, and for the city employees for making this happen. And I want to specifically also thank the city employees who allowed and made this available on YouTube so that it'll be available this evening, as well as going forward. So I thank the city for doing that. And I wish everybody a happy Thanksgiving. And keep on coming back to our meetings. So thank you very much. We're officially adjourned.
Thank you.
Good night.
Bye, everyone.
Bye. Is Rita still on, or she drop off too?